All right, next.
Dominik,
Dominik, you're next. Congenital techniques every adult interventionist should know.
All right, thanks for the invitation. Have sort of a potpourri of cases that we're going to just blast through pretty quickly, of things that I sort of, when I was thinking about what to present, I sort of looked back on my training and said, what did the adult guys not teach me that the pediatric guys did teach me? So that was sort of how I figured out what to talk about. And I also talked to my pediatric interventional colleagues who have very strong opinions about what adult interventionalists don't know, which is mildly offensive to me, but I have a pretty thick skin having worked with these guys. So actually last week, the Quinnipiac poll came out and said, and they polled pediatric interventional cardiologists, and they asked them, would you say that an adult interventionalist is a strong person? Yes, of course. Are they intelligent? Yes. Do they care about average Americans? Not really. Are they honest? This one really was offensive. I mean, I don't think we're liars, but has good leadership skills? No? Wow. Are they level-headed? No. Wow. And then really striking, do they know how to do a shunt study? No, they don't know how to do a shunt study, which is what my pediatric interventional colleagues think. So I implore all of you who close ASDs to know how to calculate a PVR in a large ASD in someone with pulmonary hypertension. This is a big problem for us in Colorado with altitude. We have a lot of pulmonary hypertension concomitant with right to left or left to right shunts. And it really frustrates my colleagues that get referred patients for surgical closures of ASDs because the PA pressure was too high, but in essence, the PVR is normal and that wasn't calculated properly. So if it were up to them, I would talk about hemodynamics and shunt calculations for an hour, but I'm not going to do that. So pulmonary angiography is something that adult interventionalists don't do very frequently, but I think it's important, especially for those of us who take care of patients with acute MI and ACS, because oftentimes folks come to the cath lab, you look at their coronaries and they're completely normal and you're kind of stuck figuring out what the heck is wrong. So you can actually diagnose a PE in the cath lab. It's not the best method. CT is fantastic. But you can do it in the cath lab, especially in patients who are sick and you're not sure what's going on. There's a variety of catheters to use. You can use any one of these. It's not really imperative that you use one specific one. There's balloon angiographic catheters, pigtail catheters of various shapes, and then my favorite that I knew nothing about in that bottom right is the NIH catheter, which is a Dacron woven catheter that we use actually pretty frequently. It's just a side hole catheter without an end hole, and you can kind of put it wherever you want to take angiograms. Just to review the pulmonary anatomy briefly, and again, this is just like coronary angiography. Your angiographic view is really tailored to the segment of the pulmonary artery that you actually want to look at. So in the AP projection, you notice that the left pulmonary artery, which kind of goes anterior to posterior, is foreshortened. So if you want to image that, it's really important to get good views, and those views are really a cranial view to kind of lay that out. If you're looking at the pulmonary valve annulus, two standard views that we use, cranial view and then this straight lateral view, which in our biplane labs is pretty easy, lays out the pulmonary valve annulus very nicely. Selective pulmonary angiography, just again to demonstrate that left pulmonary artery, which runs away from you in the anterior-posterior projection on the left side, a cranial, which outlines sort of the ostium, and then a straight lateral view, which really profiles the left pulmonary artery very well. And again, that NIH catheter, which I talked about. Pulmonary wedge angiography. A lot of adult interventionalists are like, what the hell is a pulmonary wedge angiogram? And why the heck is it important for me? So we do a lot of these in pediatric populations, but this is a case of someone who was referred to as an older woman with histoplasmosis, and you see that big calcified mass in her mediastinum, and there was compression of the left pulmonary artery, so she had concomitant pulmonary hypertension, so we thought it was really important to demonstrate that the pulmonary veins were not compressed. So the way you do a pulmonary wedge angiogram is you use what's called layered contrast, which is kind of odd to think about. So it's essentially contrast in you pull up saline, about 3-4 cc's of saline, and then slowly pull up contrast so that it doesn't mix in layers, so that the saline is on top of the contrast. You inflate a balloon wedge catheter or some other wedge angiographic catheter, and then you inject and deflate the balloon, which kind of puts the contrast in the pulmonary artery and then flushes it into the pulmonary vein, and you get an outline of this. So a lot of you are like, why is this important? So we do a lot of AFib ablations, and these patients oftentimes present with symptoms afterwards and have pulmonary hypertension, and it's not clear why. In a study that was published in 2013 by the Cleveland Clinic Group, about 4% of patients after pulmonary vein isolation end up having severe stenosis of one or multiple pulmonary veins. So this is an important technique to at least understand when it comes to evaluating these patients in the cath lab if you don't have tomographic imaging or a VQ scan to help you. Coil embolization, which I didn't learn a ton of in my adult fellowship, but I think is important for anybody who's getting vascular access, not necessarily to coil a huge veno-atrial collateral in a Fontan patient, but to get yourself out of trouble if you have an AV fistula or a pseudoaneurysm or a perforation. It's important to understand how to use coils, and really it's important to have a system. There's a ton of platforms out there. It's important to be familiar with one of them and know how to use it. In this case, sorry, Jackie, I one-upped you here. 37 Ruby coils. You know how expensive they are? $1,500 a piece. Yeah. This 25-year-old kid is worth a lot of bucks. So, but you see that we get pretty good results with a really huge nest of coils, but obliteration of that the veno-atrial connection. Actually, same case, selective angiography into one of the small side branches, and here we use an Amplatzer vascular plug 4. So again, it's just important to know these devices, have sort of an armamentarium of things that you're comfortable with, know what sheaths and catheters they go through. The vascular plugs are nice because they go through 5 French, this was a 6mm AVP4 and it went through a 5 French JR4 catheter, which is great to get into these smaller lobed side branches if you need to. Coronary fistulae. The real question for me in coronary management of a coronary fistula is if you should do anything about it in the first place. Not how you do it, but really should you even embark upon it. And the literature sort of echoes this. The outcomes of doing anything with coronary fistulae are varied, and there's really not a consensus. And it's sort of, you're poking a skunk when you start putting coils into branches of coronary arteries, because coils are meant to thrombose whatever vessel you put them in. And clot propagation is not an insignificant issue, and it's really something to be cognizant of. So before you embark upon coiling coronary fistulae, which are not uncommon, you should really give thought to whether you should or even do anything about it. And if you think you need to do something about it based on a shunt fraction or heart failure or some other indication, you should really think about whether the surgeon should be attacking that problem rather than us with coils. So in this case, it's pretty clear. This is a person who has complex congenital heart disease, had a septal myectomy, so this is an iatrogenic coronary cameral fistula off a septal perforator. And when you first look at this angiogram, you're sort of like trying to figure out what's what, because that septal is gigantic. It's bigger than the size of the LAD. And this thing is a fire hose into the left ventricular outflow tract. So again, we put a 6mm Amplatz vascular plug 4 through a 5 French diagnostic catheter, which we were able to get down that septal pretty easily. And you see that we got a good result at the end there. I think we have a talk about AV loops and rails, so I'm not going to spend too much time on this, but this is something we commonly do in the congenital heart disease world when we close PDAs and VSDs. It's something that if you're going to dabble or do structural heart disease, if you're going to get these patients with post-infarct VSDs, so this is really important. These trabeculated VSDs, which are really complex, it's really hard to get stuff across them, and oftentimes you have to come retrograde from with the direction of flow from the left to the right, and then have to snare. So here we snare a glide wire on the pulmonary artery with a simple gooseneck snare and advance a large delivery sheath over that rail, which provides enough support to make the big bend through the right ventricle and through that trabeculated complex ventricular septal defect out into the LVOT. The first time Neil Wilson told me to stick a needle in the carotid artery of a 3-kilo baby, I looked at him like he was crazy. And he, in his very British gentlemanly way, said, "Come on, Dom, get on with it." So I said, if we can put sheaths in the carotid artery of a 3-kilo kid and do aortic valve interventions, why can't we do that in adults without femoral access? And shortly after I had that sort of moment of enlightenment, this French study came out and showed that transcarotid transcatheter aortic valves replacement was not only feasible but safe. So I think this adds to our armamentarium as structural interventionalists to be able to access alternative sites percutaneously or with surgical cup down and avoiding access to the chest. I didn't spend a lot of time talking about what adult interventionalists shouldn't do in congenital heart disease patients, but it's really important that if you're faced with complex congenital heart disease and structural heart disease, that you engage your colleagues who have a lot of experience with this stuff. Because again, some of these techniques are sort of one-off things that you've never done before or don't have much experience with, whereas some of our pediatric colleagues do this every day. So it's good to have a good relationship with a pediatric interventionalist if you're doing complex structural heart disease. Thanks very much. Anybody take any questions?
Yeah, we have any questions for Dominik? I think this type of partnership, just like there are heart teams between cardiac surgeons, interventional cardiologists, and imagers, there's also kind of an equivalent heart team between the adult structural interventionalists and the pediatric interventionalists that work on patients when they turn 18 or 21 and come to your center and so forth. And it's not just the techniques, it's knowing the disease, because a lot of us will be comfortable opening a hole or closing a hole, but really trying to understand the disease and what the patients need, I think, are critical. I think those were great examples, Dominik. We've also used the wedge injection like you have, but we have gone transeptal and got into the vein.
Mm-hmm.
And if you do them that way, it's much easier to delineate the pulmonary venous stenosis than the runoff, and easier to stent too.
Agreed.
Which I know you have all these techniques on how many can you show, but those are tough problems to deal with. But great presentation.
Great. Thanks very much.